Hello, thank you all for being here today. My name is Atul Malhotra. I'm going to talk today about sleep disorders and memory. I'm actually in Austria here for the European Respiratory Society, but traveling with my daughter. And so, sorry, I'm not dressed like a very professionally today, but sort of my vacation. So, um, it's my pleasure to be here today. It's quite an honor to share the podium with such distinguished speakers for the symposium set up today. I'm a pulmonary critical care sleep medicine physician. I do a lot of research related to sleep disorders, and I oversee the research for the Department of Medicine at UC San Diego. The outline of my talk today, I'm going to talk about diet, exercise, and sleep as the three pillars of health. I'll make the point that we all need 7 to 9 hours of sleep in a 24-hour period to optimize function. Sleep disorders are often linked to memory impairment, as I'll show you. Sleep disorders are very common and should be prevented and treated. We'll do a little bit of tips for improving sleep quality. So Ezra Tisali and Karen Spiegel and others published previously about the impact of sleep duration on metabolic function. And we know metabolic function obviously is important in AD and ADRD. What they did at University of Chicago was induce sleep deprivation in normal, healthy people. And you could start to see impairments in glucose tolerance. So-called glucose effectiveness becomes abnormal in perfectly normal, healthy people who are sleep deprived. It's thought to be through sympathoexcitation, increases in counter-regulatory hormones such as cortisol. And so sleep deprivation may contribute to insulin resistance. Slow wave sleep or deep sleep may be particularly critical. When Dr. Tisali suppressed slow wave sleep or deep sleep, just by lightening sleep, you could start to see insulin resistance even without waking people up. There's also important effects of sleep deprivation on obesity and obesity regulation. So leptin is a hormone made by adipocytes that suppresses appetite. Ghrelin is the opposite. It promotes appetite. Leptin works through the ventromedial hypothalamus as a satiety hormone. And what they did here at University of Chicago, published in the Annals of Internal Medicine, was they randomized subjects to get either adequate sleep with 10 hours per night opportunity or 4 hours per night sleep deprived. And they did it under constant glucose infusion, so it wasn't that they're eating more or eating less. And the y-axis here is the leptin levels. The y-axis here are the ghrelin levels. When we look at sleep-deprived individuals in the dark lines here, their leptin levels are suppressed and the ghrelin levels are increased. Both hormones go in a direction that be predicted to stimulate appetite. I'll say it again. Both hormones go in a direction that be predicted to stimulate appetite when you're sleep-deprived, even under constant glucose infusion. And so Jeff Flyer, the dean of Harvard Medical School at the time, wrote the editorial about this article in the Annals of Internal Medicine and suggested that sleep deprivation may be one risk factor underlying the obesity pandemic. So we saw that. We went back to the Nurses' Health Study and looked at this paper, which we published in the American Journal of Epidemiology back in 2006. The nurses were asked back in 1986, how many hours do you sleep in a 24-hour period? There's about 70,000 nurses that were involved in the questionnaires. The y-axis here is body weight. X-axis here is time. If you look at the women sleeping 5 hours per night, they weighed more at baseline than women sleeping 7 or 8 hours at baseline. And then you can see that the people sleeping 5 hours per night gained more weight over time than did the people sleeping adequately. Everybody gained weight during those 15 years, including me, but the 5-hour sleepers gained more weight over time than did the people sleeping adequately. And this suggests that sleep deprivation is at least associated with weight gain. And this is independent of known covariates. We have a huge sample size so we can control for whatever covariates we want. And these data are independent of known covariates. There are also some randomized studies that have been done looking at people undergoing a diet. So reduced energy intake is going on a diet. And they randomized again patients to get sleep curtailment, that is not adequate sleep. And what it did is decrease the proportion of weight loss as fat by 55% and increase the loss of fat-free body mass by 60%. So the sleep deprived versus not sleep deprived, the sleep deprived people lost less weight, at least body fat, while sleep deprived. So it concluded that the amount of human sleep contributes to the maintenance of fat-free body mass, the times of decreased energy intake, that is going on a diet. Lack of sufficient sleep may compromise the efficacy of typical dietary interventions for weight loss and related metabolic risk reduction. We're learning more and more about metabolic risk and the association with Alzheimer's disease. And we believe sleep deprivation, at least one causal pathway, may be related to metabolic dysregulation affecting cognition. So next I'll talk about we need 7 to 9 hours of sleep in order to optimize function. Why do I say that? Well, David Dinges at the University of Pennsylvania has probably done the best work in that area. We published this in the American Journal of Respiratory Critical Care Medicine some years ago now, giving recommendations for healthy people 2020, recommendations for healthy sleep. The federal government puts out statements once in a while to promote good health, and this is a statement we gave to help inform that discussion. David Dinges at the University of Pennsylvania has probably done some of the best work in this area. We published this in the American Journal of Respiratory and Critical Care Medicine a few years ago to help inform Healthy People 2020. Healthy People are documents that the federal government puts out from time to time to help improve overall health. And in order to inform that document, we wrote this about healthy sleep. David Dinges has done experiments in that context and determined almost all of us require between 7 and 9 hours of sleep in a 24-hour period for optimal function. There's actually a measurable decline in cognitive performance after 18 hours of sleep deprivation. So if you wake up at 6 a.m. and go to bed at midnight, over the course of that 18 hours, there's a measurable decline in cognitive performance. It's about in the order of 1 or 2 drinks. It's not a huge effect, but if you drink a little bit of alcohol, it affects your cognition. So does a little bit of sleep deprivation. And Drew Dawson, Adelaide, Australia, has done some nice work in that area, published in Nature. If you're awake for 24 hours, though, you're actually legally drunk. So if you're a post-call intern, your neurocognitive performance is really quite impaired. And that's quite concerning for doctors in training and others. Optimal neurocognitive function may require a full 9 hours in a 24-hour period. So why do I say that? On the y-axis here is the Stanford Sleepiness Scale. It's a subjective measure of daytime sleepiness. And the y-axis here is the Psychomotor Vigilance Test. It's an objective test of brain function. So here's objective brain function. Here's subjective sleepiness. And the x-axis here is time. And the x-axis here is also time. And what they do at the University of Pennsylvania is they'll sleep deprive people. And so here's total sleep deprivation. Not surprisingly, subjective sleepiness gets worse and worse. With total sleep deprivation, the more and more lapses on the psychomotor vigilance test, suggesting worsening objective brain performance. So worsening objective brain performance with total sleep deprivation, and worsening subjective sleepiness with total sleep deprivation. If you look at 8 hours of sleep per night, subjective sleepiness is quite flat, and objective brain performance here with 8 hours of sleep is also fairly flat. What's more interesting are these curves. People sleeping 6 hours per night or 4 hours per night have increases in their subjective sleepiness, and people sleeping 6 hours or 4 hours per night have more and more lapses on their psychomotor vigilance task. What's interesting here is these curves have plateaued after a couple of days. So if you ask this person, you sleepy? They say, yeah, I'm sleepy, but I'm used to it. There's no hint of a plateau in either of these curves, suggesting objective brain performance is continuing to get worse over time, even when subjective sleepiness is quite flat. So take a message here is that we lose the ability to perceive how sleepy we are. Our subjective sleepiness is quite stable, while our objective brain performance is deteriorating. And the other thing to note here is that 6 hours and 4 hours look very similar as far as subjective sleepiness is concerned. But there's clear separation between 6 hours and 4 hours of sleep in terms of objective brain performance. So you can hear the conversation now. People say, well, I might as well stay up all night. I'm going to feel crummy tomorrow no matter what. And that might be true as far as subjective sensation is concerned, maybe not true for objective brain performance. So the take-home message here, once again, is that we lose the ability to perceive how sleepy we are when we're sleep deprived. Our subjective sleepiness and our objective brain performance are dissociated. We're not good at judging how impaired we are when we're sleep deprived. Sleep disturbances are also linked to memory impairments. I'll talk more about that. There's a thing called memory consolidation. That is when we are learning things during the day, we may or may not remember them tomorrow. And some of that happens overnight is sleep dependent. It's referred to sleep dependent memory consolidation. And Bob Stickold, my colleague at Harvard Medical School, did some of the best work in this area, published in Nature and in Science and other leading journals, suggesting about 80% of the variance of what we remember tomorrow, we can predict by how well you sleep tonight. But 80% of the variance we remember tomorrow, we can predict by how well you sleep tonight. It's more important than your age, your IQ, or your race, or your gender, or where you went to college, or how smart you think you are. About 80% of the variance of what you remember tomorrow, we can predict by how well you sleep tonight. Chronic effects are less well studied, but certainly it's the case that good night's sleep is an important part of consolidating memory. So obstructive sleep apnea is a very common condition, as we'll talk about. This is where people stop breathing when they're asleep and they wake up, and they stop breathing, they wake up. This falls in oxygen levels as well, which can take a toll. And so that's a common disorder which I spend a lot of time studying. There's some association, at least, with Alzheimer's disease risk. So obstructive sleep apnea has been associated with incident of Alzheimer's disease. This is a paper by Yaffe published in JAMA, which I'll show you more on the next slide. Treatment of sleep apnea improves memory consolidation in randomized trials. So Ina John Logic is my colleague. We published this article in the American Journal of Respiratory and Critical Care Medicine a few years ago now, looking at 3 months of CPAP treatment. CPAP is continuous positive airway pressure. It's first-line treatment for obstructive sleep apnea. We gave that to people who improved their sleep quality. You could also see improvements in their overnight memory consolidation or their sleep-dependent memory consolidation as compared to control group who got diet and exercise as a standard of care. Sleep disturbance is associated with amyloid and tau deposition in the rodent and human brain. So the Holtzman group at WashU in St. Louis published some beautiful articles in Science and other leading journals suggesting that sleep disturbance in both rodents and humans can contribute to amyloid and tau deposition in the brain. And this paper is a bit controversial, but even a single night of sleep deprivation can increase brain amyloid accumulation. So you study the same individual before and after overnight sleep deprivation, you can start to see amyloid changes. Whether that predisposes to Alzheimer's or not, we don't know, but that paper was controversial, but suffice to say the changes were quite interesting. So this was the JAMA paper that I just mentioned, sleep disorder breathing, hypoxia, and the risk of mild cognitive impairment and dementia in older women. It was an epidemiological study, suggested sleep apnea and risk of cognitive impairment from a large cohort. The mechanism may be genetic. The ApoE epsilon 4 is common to sleep apnea as well as to Alzheimer's. Maybe oxidative stress, the low oxygen or the reoxygenation can contribute to oxidative stress. Sleep fragmentation, as I mentioned, they stop breathing, they wake up, they stop breathing, they wake up, and that may contribute to memory impairment and perhaps AD risk over time. Sleep apnea can also yield depression in epidemiological studies, and so some have suggested this term that's now antiquated, but pseudo-dementia, where poor mental health may contribute to a false diagnosis of dementia, or at least the pseudo-dementia. Then treatment of sleep apnea can improve sleepiness and cognitive performance. Whether it prevents Alzheimer's, I don't think we know yet. These are some data about the memory consolidation I mentioned. So Ina John Logic's my colleague in Boston, who I used to work with when I was there and continue to collaborate with. So obstructive sleep apnea patients are shown on top. Controls are shown here below. And this is evening testing and then testing the next morning. So we studied the overnight effects on memory consolidation for certain tasks. There's an initial improvement and then a plateau improvement that you can measure in both sleep apnea and in controls. And so one way to look at that that's more helpful is to look with these bar graphs. Here's the percent improvement on the y-axis, percent improvement here on the y-axis. The initial improvement is much less in sleep apnea compared to controls. And the plateau improvement is also markedly less in sleep apnea patients compared to controls. And these data suggest that sleep apnea may contribute to impairment in memory consolidation. This is for a particular motor memory test. We believe it's true of other tests as well. Interestingly, only the arousal index that we measured was predictive of impairments in memory. Low oxygen levels, other things were not, although I'll point out the Yaffe study in JAMA, it was the low oxygen levels that appeared to be the culprit. So there are multiple mechanisms in play here. So what do you know about sleep fragmentation? The EEG has predictive value, at least for sleepiness and for memory consolidation, as well as for glucose regulation. David Gozell has actually shown effects on cancer growth as well. And so this fragmentation of sleep obviously has wide-ranging effects. The assessment of sleep apnea without assessing sleep is likely to be incomplete. That's not a surprising statement to people who study neuroscience, but many of us in the respiratory field will rely on home sleep testing, where you're measuring respiratory airflow and oximetry, but there's no assessment of brain activity. And that may be problematic, although that's sort of what the insurance and healthcare reform is sort of forces us into. These home tests do not monitor sleep as well as in-lab polysomnography, which gives a lot more information about the brain. So the other thing to talk about here is that sleep disorders are very common, should be prevented and treated. Why do I say that? Well, we've estimated, based on the apnea-hypopnea index greater than 5, about 1 billion people worldwide with obstructive sleep apnea. The apnea-hypopnea index is the number of cessations plus reductions in breathing per hour of sleep. We did an epidemiological survey of all the published literature from across the world, which is about 5 years old now. It estimated about 1 billion people with obstructive sleep apnea. You might argue that's sort of a generous definition for sleep apnea. If you raise the bar and say, okay, you need an index over 15 events per hour, where there's really no debate that treatment is required, we're still talking about 500 million people worldwide. So sleep apnea is really quite common. So if you raise the bar to 15 per hour, still about 500 million people, or over 400 million people worldwide with obstructive sleep apnea. That number is getting worse, not better. Despite some innovations in obesity therapy, society is getting more obese, not less so. And so these numbers are getting worse, not better. You might say, who cares? Why do we care if there are people out there who don't come to clinical fruition unless they come to the doctor? Leave them alone. Well, we published this study from Switzerland, where Raphael Heinzer, my former trainee, is now independent and doing very well in Lausanne, Switzerland. Did the so-called HypnoLess study, where they went and did polysomnography in the homes of people in Switzerland. I'll point out the obesity problem is much less in Switzerland than it is in the United States, although they're catching up. But suffice to say, when he did that, he saw that about 23% of women, about 50% of men had an apnea-hypopnea index over 15 events per hour, so a breathing problem once every 4 minutes, where there's no debate that treatment is required. So again, you might say, who cares? These are people in their homes, in the community. Leave them alone unless they come to the clinic. Well, when we looked at the apnea-hypopnea index, it was predictive in multivariate analyses of hypertension, diabetes mellitus, and depression, all diseases we take quite seriously. So it's hard to argue just leave these people alone and ignore them when they're afflicted with conditions we all consider to be quite important. And so we argue that the global burden of disease is quite high. And there's a concept here, sleep apnea is highly prevalent, but not all are likely to get cardiovascular benefit from CPAP. Some of the clinical trials on CPAP, continuous positive airway pressure, have not shown much benefit, but it might be that 50% of men in Switzerland are not at cardiovascular risk. Some are at risk of Alzheimer's, some are at risk of cancer, some will get heart disease for other reasons. And so we probably have to be more selective about who we include in various studies. This is what CPAP looks like. It's continuous positive airway pressure. It's sort of got a bad reputation for reasons that aren't clear. There are many patients who tolerate it quite well. I'll show you some data suggesting the majority of patients can tolerate it well. Again, I don't have conclusive proof that it will prevent Alzheimer's. I do have pretty good evidence it can improve memory consolidation and symptoms, but whether it prevents Alzheimer's, I don't know. Some suggestive data that amyloid and tau may be improved. We're actually studying this now with Sarah Banks and others at UC San Diego. So CPAP, continuous positive airway pressure, often gets a bad reputation that nobody tolerates it. That's simply not true. There's a group called the MedX Cloud, which is an academic industry partnership. I'm a member of MedX Cloud, but I don't take money from either MedX Cloud or from ResMed, which is the corporate partner. They did give a philanthropic donation to UCSD, which I should disclose. And the x-axis here is time, and the y-axis here is the cumulative percent of patients. If you look at usual care, about 70% of patients will meet adherence criteria for Medicare in terms of CPAP, and so 70% is pretty good in terms of adherence to therapy. If you look at patients getting modern technology, they get patient engagement, where they get a thumbs up if they're doing well, they get helpful hints if they're doing poorly. We're looking at almost 87% of patients here getting adherence to CPAP therapy based on US Medicare criteria. This is drawn from almost 1 million patients, from 137 million nights of recordings, and these two groups are propensity matched with, so that the on similar characteristics here, patient engagement seems to do quite well, but even usual care does reasonably well as well. There are now over 15 billion nights of data on the cloud, and so we're able to do these large-scale studies in ways you couldn't imagine prior to that sort of technology and prior to big data innovation. So I'll close with a few tips about improving sleep quality. These are important things to tell our patients, but they're good for us as well, for providers and for educators about just general sleep. These are tips for good sleep. If you snore or suspect a sleep disorder, talk to your doctor. Maybe have sleep apnea or maybe at risk of sleep apnea. If you have insomnia or trouble falling asleep or trouble staying asleep or early morning awakening, avoiding alcohol can be helpful. The joke we have is do all your drinking in the morning because if you drink alcohol at night, characteristically, people will wake up once the alcohol wears out of their system. Avoiding tobacco and caffeine are good for various reasons. Caffeine can certainly disrupt sleep, as can tobacco. Avoiding erratic bedtimes. And so if you have a problem with insomnia, regularizing the schedule could be quite helpful. Avoiding napping. So if I take a nap on a Sunday afternoon, I can't sleep Sunday night, not because I have insomnia, but because I'm not tired. And so sometimes that homeostatic drive can be part of the issue there, and just avoiding napping can help people sleep at night. Avoid activities in bed apart from intimacy and sleep. Patients playing video games or watching movies or these things, and they get conditioned to be awake in bed, and that doesn't help anything. Avoid the alarm clock. Some people perseverate on that and fixate on it, and just avoiding that if you're having trouble sleeping, get rid of it. And schedule worry time. Some people start worrying at 3 in the morning rather than 3 in the afternoon, and sometimes making a list of all your troubles at 6 in the evening can actually help you sleep at night as well. So I'll summarize by saying sleep is an important component of health. We mentioned diet, exercise, and sleep are the 3 pillars of health. Sleep disturbance can certainly impair memory, as I showed you. Sleep disorders are very common and require treatment, and to the extent we can do prevention there as well. And so the message overall is that sleep is important. Your mother was right. It's an important component of overall health and wellness. So I'd like to stop there. If there are questions, you can email me. I'll be happy to answer whatever I can. Thank you.